Hi everybody, a little bit different today. Thanks for coming along. Thanks for giving up your lunch time this afternoon. So yeah, going to do something a little bit different because we've been doing these for a good 3 months now, haven't we? And we've pretty much picked a different topic every week. We've picked a penguin, a pathology, or something specific to treat, a part of the body to treat. And we tried to cover pretty much as much as we can in the last 3 months. Before we do something slightly different, a bit of a Q&A for Paul. Most of you will have met Paul, albeit over Zoom in recent times, but those of you may have met Paul before when we did it back in the old-fashioned way, where we used to go to people's clinics and do demonstrations. So what I'm going to do is I'm going to go through a few slides, kind of a base for us to talk from, really, but really want to encourage your questions to come in. You know, there's no pre-script for us. We've not prepared anything specific. Really ask the questions as you go along. But so we've got some structure. I'll just go through a few slides. Some of you out there that have already got the laser, then you'll know some of this already. So feel free to interject with your experiences as well. So I'll share the screen now, just for ease. If you could all remain on mute, that would be great. But ask the questions as we go along, by all means. Pop it in the chat. And normally I ask the questions on people's behalf, but I'm quite happy to unmute and we have a bit more of a chat today. We'll see how that goes. So if you want me to ask a question for you, no problem, I'll do that. But if you don't, if you want to come on and ask the question directly to Paul, just pop the question on the chat to me, and I can unmute you, and you can have that kind of conversation, if you will. So what else is to say? You all know Paul. I was going to introduce Paul. I've already done that. Let's get a few slides up. Bear with me a second. So does that sound okay to everybody? Does that sound like a bit of a plan? We can make the most of the next 40 minutes or so. Thumbs up if you're happy with that, or down if not, or throw a question into me or what have you as we go. So here we go. So you know who we are. You know I'm Steve from, well, maybe you don't. I'm Steve. I'm Steve from Celtic SMR. We are Celtic SMR, and obviously we're very proud to be the UK distributors of the Class 4 MLS multi-lot system from ASA. Doing really, really well. And there's a few key points about our particular laser. Can you still hear me, Paul? You can, yeah?
Yeah, I can hear you, yeah.
So here you go. There's the introduction. A lot of you know this. By the way, these slides that I'm going to do, I'll share these with you after today. So don't worry if you don't catch. We'll skip through some of the slides. There's 23 slides there. We won't go into every detail on every slide. But I will follow up with an email that you all get a copy of this if you'd like to. So there you go. A bit of an introduction. As I say, it feels like I'm preaching to the converted, because most of you on here will know all about it already. But for those of you who don't know so much, it's Class 4. It's a unique technology. That's the MLS bit, which Paul will come on to a little bit later on. Easy to use technology, very easy to use. We get a lot of feedback from our users on that. Very self-intuitive and so on and so forth. More and more evidence. I get anecdotal evidence all the time. Peter just came on now and just told us a little bit how well things were going with tendon injuries, I believe. Every time I speak to someone, they're telling me what great results they're seeing. And so we've got scientific evidence. We've also got lots of anecdotal evidence, and that just keeps growing. Okay. One thing ASA are pretty good at, is that slide moved? There we go. They do put quite a few articles together. This one, I believe, is on plantar fasciitis, I believe. Or is it? Let me double check. So there's plenty of articles out there if you want a bit more reading on the successes and the history behind it, and the Then the other thing to consider, and this is where I'll probably stop talking myself and hand over to Paul, but basically the mechanism of the action, there's three elements to that. There's the chemical, there's the thermal, and there's the mechanical. And we talk about the two different wavelengths of light. So anything you want to add on that, Paul? Anything in particular, or is that straight?
No, well, the only thing I would add is considering, you know, people get a bit confused about lasers, you know, power and everything like that. It's very simple. Class 3 is up to half a watt, 500 milliwatts, and above that is a class 4. But when we're actually delivering power with this laser, it is literally the only laser on the market, and it's because of the patented system, which can actually deliver the two widths of light doing separate things at exactly the same time. Now, one of those widths is not massive power. It's 1.1 watts is the 808 nanometers, but it's well into the class 4 specification. But the other is at 25 watts. And I think this is one thing which people sometimes get a little bit confused about. We're delivering masses of power there. There are some machines which do 75 watts. And that you're thinking, well, that's too much. Well, it would be too much. You'd be just burning a hole in the person if it wasn't controlled. And it's all about how you can get this extra power into the body without causing the obvious things, the obvious damage which will occur, because once you start sticking in masses of light at high power in that therapeutic window into the body, you will start heating the tissues. And somebody asked you a question the other day about HILT, high intensity laser therapy. We're actually talking about something else slightly different there, because that is just sending in the huge amounts of power, but you will have to move this because you will just cook the person straight away. And therefore we've got a danger going on straight away. We don't want to do that. And this is, I suppose in a way, MLS has created its own unique subsection, because it's not a low-level laser, but it is relatively cold in terms of what it's doing because of the way it delivers it. And it delivers laser photobiomodulation at very, very high power, but you don't get the thermal damage because on that 905 nanometers, whether it's 25 watts or 75 watts, it is super pulsed. And it's the only system. All the other lasers will tell you, yes, we are pulsed. They're not truly pulsed. They might have different hertz. When we talk about our continuous wave, the 808 nanometers, we can make it continuous at 1.1 watts, but most of the time the default setting is frequency. It is frequency. So it's on, you can have up to 2000 hertz per second. But in the real world, when we're talking about a nanosecond and we're talking truly about super pulsing, that 2000 times a second, it's on forever, really. It's just on, off, on, off. Okay, it's an awful lot of times, but that is big amounts of time it's on. And that is the one way which we can look at later, how we can increase the joules up to, you know, really quite impressive areas, which could possibly on an acute pathology cause a rebound effect, but you can, on a more chronic thing, you can actually get incredible changes because you're delivering such big power. But the 905 nanometers is super pulse, a millionth of a second, a nanosecond on, nanosecond off, nanosecond on, nanosecond off. So you're getting the effects of the high power. You're getting the thermal effects without the thermal damage. And that is quite remarkable. And not only that, you're getting these two widths of light sent at exactly the same time, synchronized. No other laser can do that. No other laser has the ability to actually send the two widths of light in at the same time. They will also, no matter how many widths they put in, they'll go 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4, like that. What this is doing is this is actually sending in, we've got two here, 1 and 2 in exactly the same time. It is together, exactly together, synchronized. So this is the only time, the only system which will give you a complete synergistic effect, because what one wave of light is doing to help the body will actually partly help the other wave of light, which is going in to help the body in a slightly different manner. And the big area, which I think is so important on MLS, is pain. And every time I speak to anybody, and I'll speak to you all about this, pain is our enemy. Pain is not the friend of the podiatrist or the physiotherapist or the osteopath. It's a problem, because once you have pain, people go into avoidance. They will not do the stuff they need to do, and they need to do stuff. So if we can get them doing their work, how are we going to do it? We get rid of the pain, reduce the pain, and then they start doing it and thinking, well, actually, I can do this. And as I've always said, this machine isn't the answer to everything, but as an adjunct to doing what we have to do as physiotherapists or podiatrists, it is the answer, because this allows the tissue changes. It allows the reduction of inflammation. It allows the reduction of edema, and it allows, stops the pain pathways, sending the pain message to the brain all at the same time, which then allows us more to be able to do the physical stuff which we need to do. Sorry, I went on too long as usual. Sorry.
It's all right, thank you. If you're wondering why I came off the screen there and took the slide.
Was I talking too much?
Yeah, I turned off. No, not at all. I have to come out of this screen to go and check if there's any questions come in. So that's why I'm jumping back and forth. So bear with me.
Okay, so I'll shut up now.
No, okay. No, don't do that. Wouldn't be a great 45 minutes an hour if you didn't talk, Paul. So I think there's quite a lot of detail on the next couple of slides. Paul's talked quite a bit there about so I know a lot of you will know some of this, but it's never a bad thing to refresh the memory, because it's a great way of promoting the product you have in your clinic to your patients. Let's try this. This is different. This can really help, kind of thing. So refreshing your memory of some of the background to it is never a bad thing. You're not going to go into as much detail with your patients. I completely get that, but some of this detail might be something that you want to pass on again. So you can never hear it enough, I guess. But I think a lot of this is just more, again, we've got the chemical, the thermal, and the mechanical. Okay, so we'll move on from that. The indications, we know it's great for muscle spasms and pain. We also know it's good for anti-inflammatory and reduction of swelling. I did have a question around the biostimulation and edema settings, so I'll remind myself of what they are in a moment, Paul, but maybe I can keep that till the end.
Well, okay, Steve, I was just going to say, while you're on this, well, go to the other side. When you're on that slide about the anti-inflammatory aspects, again, you can read the scientific stuff, what it does, but and I think you've got a slide in there which you can show people, but I don't know if you're all aware, I know you've released it a little bit, but an orthopedic surgeon in the United States, in Massachusetts, Mr. Scott Sigman, he approached the FDA, and with the knowledge, because he uses this in his clinic, and he knows what an effect it has on the, what an anti-inflammatory effect it has. It's quite extraordinary. So he proposed that they trial the Charlie head, the laser, on severely ill COVID-19 patients. I think that the new one is probably out in the next day or so, but they've done already one a pilot study, and they got a 57-year-old African-American in severe difficulty with COVID-19. It was a question of could they stop him being put onto the ventilator. His saturations without oxygen were, well, he needed to be on 6 liters of oxygen, and he was still even just going up to 90% saturations with that. And what they did was they trialed him. They did 4 days of laser with him in the prone position over the back. Now his arms are spread out so they can actually move the scapula and they can get through the back. This, as we know, will go 5-6 centimeters deep. What they did is they started the laser session. As I say, 14 minutes each lung, covering each other. And I think it's probably round about, they're working on the basis of 7 joules per square centimeter, I think. I can't remember. Round about that. That's the settings they did. Within 5 minutes of the application on the lungs, this man's saturations went to 100%. It's just quite a bit too good to be really, you know, how is this happening? In fact, they finished the session, and after the first session, they put him back on the ITU bed in a sort of semi-sitting position as much as they could, and his saturations remained at 98% for the rest of the day. Over the 4 days, 28 minutes each day, they forgot about any ventilation. They actually moved him out of ITU into a rehab facility, and they started physiotherapy and stair climbing and various activities. And so this man was, you know, he wasn't in the situation of going on the ventilator. As we know, you go on the ventilator, 50% die, 50% live. Yeah, here's the little thing. So it's a very interesting read, and you can see the changes on this slide, which Steve's put up, the changes in the lungs. So much of that white has gone, and it's been replaced by black. Now, what's happened is the FDA had said, whoa, baby, this is a bit amazing, and they've actually ordered a whole load more trials, and I think it'll just increase. But especially when you consider the United States, have they lost 170,000 people dead now or something? It's gone totally out of control. And they are putting so many people on ventilators who are just dying. If they can stop the ventilation, then you've got, you know, you're halfway to actually sorting out the problem. So I think it's worth considering. I think it's very, very clever of Scott Sigmund to actually say, look, this has this anti-inflammatory effect. Let's use it on the COVID-19 patient, and they've done that, and they've found something which seems to be a bit too good to be true, but it ain't, because it's working. And I think the further papers are coming out in the next few days.
All right. So tissue repair. Anything that we haven't covered on that? We've done as I say, we've done aches and pains and biostimulation. See what we've got, seeing that, and then indication. And this is quite an impressive list, I think. Whenever I'm talking to people that are interested in the laser, want to have a look at it, try it, and what have you, question I often get is, you know, how does it compare to other modalities? I'm going to say the S word, shockwave. It's the last time I mention it. And I think the versatility of our machine, of the laser, sets it, you know, above, as great as I've said it again, shockwave. Greater shockwave is. This is, so it's quite an extensive list of the kind of things that you can be helping your patients with. So that's just a summary of the indications there. And we've got 1 or 2 other slides. This is the plantar fasciitis one. So there's some really good articles out there. If you ever want links to these guys, just drop me a line. We can always get our hands on these for you and send you the relevant links and so on and so forth. So there's always good articles out there. That was really just in part of this presentation, is just to highlight that effective MLS laser therapy on pain and satisfaction from musculoskeletal conditions, a retrospective study. So again, lots of there. Those of you who want to read up a bit more, there's plenty of reading there for you. Paul touched on this, the MLS. I mean, and again, jump in any time, Paul. But this really is what separates this laser apart from any laser previously. And again, this is useful for you users out there that already know this, to share that with your patients. But those of you listening in that haven't yet had a closer look at the laser, this is the bit that really does set it apart. You know, is it a low level laser or light laser, or is it a class 4? And it's the MLS that really kind of sets it apart. So we're getting the power of a class 4 without the thermal effect of the class 4. And you know, so
well, Steve, it's not the class 4 element. It's actually the high intensity, i.e. it's doing the same thing as high intensity, but without the dangers, okay? So it's not, if you're going high intensity, it's a slightly separate thing. We've got low-level laser, class 3B, and then we've got the high power, and what they're high peak power. Now, we're in the high peak power. Even in high peak power, depending on what you're doing, you will actually cause damage if you're not careful. You cannot cause damage with this just purely on the super pulsing of the 905 nanometers wave. And all the research, and I'm sure you've got stuff there, see which you could let people see, but they've done a lot of research on this, and you could leave that laser on a patient 20, 25 minutes. You forget, go and have your lunch, and you start on, a time which is a bit ridiculous. You're not going to burn them, because the most it will go to is 42 degrees centigrade. They'll probably have an awful rebound effect because you've sucked so many joules into them, but that's a separate matter. You're not going to burn them in any way, because it's just so specifically done. Once you get, if you don't have that, you'll start getting up higher into 43 where you're really feeling the problems. And at 45 degrees, that's where the tissue damage occurs. And you just can't go there. So it is just 100% safe.
Brilliant, thank you. So a lot of these slides are kind of repeating themselves, but it kind of highlights the point even more, a little bit there about the classifications and so forth. So any questions? Let me just double check. Actually, I have had a question come in. Thank you, Brendan. So on the TMJ pain, Paul, do you use it at all for that?
I don't. I know I can check with, is it Karen, who works at the dentist down the road.
Okay.
Because she is big and she uses it for on oral dental stuff. They have big clinical outcomes for them. Financially, they're making so much more money, because what they do is they use the laser when they're doing orthodontics. They've got the braces being put on, and they can actually get people's teeth straightened in half the time, because they keep on tightening up the braces much quicker than it would be done normally. But then they use the laser as well to reduce pain. So they're getting twice as much done in half the time by using that. And I know she'll use it on, and I think she's written some stuff on temporomandibular joint. But I would suggest you probably just trial it out, probably about 4 or 5 minutes, round about 700 hertz, which it just seems to start off with, just a general area. Probably, I would start 700 hertz, 50% intensity. Probably, it's not a big area, 3-4 minutes, 4 minutes maybe, and just try that out. I'd give it a little scan first, a 4-minute scan, and then just go in points around the areas on there. What I would do then is I would say, look, call me back in 24 hours. And how's it feeling? If they're not feeling anything, come in tomorrow. And because this is going to take 10 minutes, you can do this very easily. Then get in there, just stick up the intensity a bit. Stick up the intensity. Try again. Bring them up. Any difference? No, exactly the same. Okay, bring them back in the next day. Put a bit of CPW in there and see what happens. Always start lower and then build up.
Brilliant. You preempted one of the question actually from Brendan. So Brendan, did I answer your question? Brilliant. Because there are no presets on our units for this. There is a separate unit, a different unit that ACES sell.
The dental machines will have it, I bet you.
Yeah, exactly. Yeah, they have a different one. So it's not a preset for our therapy one. But as we.
But we all must understand the set, what they put on there, the set parameters they have are there to be changed if you want. What they are, they're genuinely, I would always say they're generally more of a subacute setting where it's going to work. It's not in the total acute situation, but subacute, where we can actually start going and they're not giving you settings which is going to cause any rebound straight away. If you take one of these settings and you think, wow, let's stick in a bit of CPW on the first one and go, let's say it's already on 50%, and you go up to 100% and you put in CPW, you're liable to have a rebound effect, okay? It's not sensible, especially if it is a fairly acute condition. If it's chronic, if they've had this a long time, and there's so many people I'll get in there with, it's on the settings on here, on the itis ones, the anything with itis on there, the settings are going with an itis, i.e. a real, more of an acute injury, more of an acute pathology. But so many of these things, people only come to the physio after they've had it for 3 or 4 years, and this thing's going out of control. Well, I know it's chronic. I will always stick the intensity up straight away on this person. I won't go first off into CPW, the continuous wave. I will give them, as much intensity as I can and try that. See how they are. If there's nothing there, next time I might go CPW. But I will always, on that very first thing, I'll give them more because this is a chronic problem.
And as a general rule, I think, is it fair to say that if it's acute, it'll be low hertz and chronic would be higher hertz?
That's it. I mean, if you look at the trigger point setting, you just press that. The trigger point setting, trigger points by nature are an acute phenomenon. You might have had somebody with a very chronic plantar fasciitis for 5 years, but the trigger points are acute. They're something which is causing problems as well. They're an acute phenomenon. The setting on there is 100 hertz, which is hardly anything. I think it's 20 seconds and 25% intensity. So it's low intensity, low hertz, okay? There is that specialist little system which we use if we have just a real painful point where we actually stick the hertz down to 10 hertz, which is absolutely nothing. But I stick the intensity up a little bit. And that has a pretty miraculous effect. Now, I'm not 100% sure of the science of how it's doing it, but it's my little miraculous thing if something else isn't working.
It is pretty amazing, actually, when you have, I've had it done myself, and I just couldn't believe it. So sort of sticking on around this kind of topic, are there any rules of thumb, shall we say, when you might use a global approach as opposed to, say, a trigger point approach? Or
well, no, it's you've got to see what the patient is. The patient might come in, and we can do. It's what we're going to do. It's with patients with a lot of this cervical postural syndromes. What I'll often do then, there's 2 ways I would go about that. One is actually scan it, 4-minute scan. I'll get in there just some points of on the neck. There could be some arthritis in the neck. We could actually have a look at that, but might just do some muscle contraction where it's all in a bit of a spasm overall. That's probably more likely to use that. So now I've probably spent about, if I put it on, what would it be on muscle contraction? I think it's 5 minutes. Okay, I found a really, let's say in the abstract, it's really contracting there. But then I'll go searching, so I've spent 9 minutes actually, which is longer than I really want. But then I find some real nasty little trigger points. And then I'll go in, 20 seconds a shot, just go and find them, probably 2 lots of 20 seconds, you'll calm these things down, and the person's going to be feeling so much better. There might be a situation where you feel, right, let's just go and doing levator scapular stretches, upper trap stretches, all this stuff. And what we really want, there's no major muscle spasm, but all we need to do is some trigger pointing. So there are occasions where, look, we just get the hands-on work, or we get them working on it, get the massive flexibility, stretching, everything that's involved that they need to do. Concentrate on the posture once they're going like that. In one of the little webinars I did, it's a nice little thing to just explain to people. Yes, it's a nice little thing to do. Hang on.
I'm just checking the questions. I've got one or two coming in now, so I will interject.
Okay. But here, we've got a 4 kilogram weight here. If I stick it on here, I can sit all day with it, okay? If I hold it out in front of me, I can't hold it for very long, okay? Why have I become weaker? No. It's the very first thing you ever learn in physics, levers, okay? Once I hold that out there, the center of gravity is the same distance behind me, okay? That is a big problem. So what's happening is the muscles which are holding up this weight are having to work so massively, it's causing problems. And this is where we get the trigger points. Your head weighs a little bit more than that. That's about 4.5 kilograms. This is 4 kilograms. And that, I tell you, that's quite a lot, okay? Get yourself a 4 kilogram weight, hold it out in front of you, see how long you can hold it for. Therefore, once you start going in, once you look at a person and they're like this, internally rotated on the shoulders, head forward, bit of a poking chin, right, the muscles which hold up this head are your levator scapula, are your upper traps. And what they're doing is they are holding that weight out in front of you, 4.5 kilograms, and they are going crazy. And then people wonder, why have they got this pain? Right, what can we do to sort that out? The first thing we do is just get them, get the center of gravity where it should be, teach them very basic things. I teach people, think of Jesus, you know, early pictures of Jesus, but he'd always just stood like that with his hands out like that. That stops you going, stood around like that in internal rotation. So come here. It brings your back, brings your chin back, brings you up straighter, and we've actually got the center of gravity going where it should do. Once you do that, we can get rid of the trigger points, because then what we do is we get in with the laser, and I might just do the trigger points on. So I'll just spend, you know, 10, 15 minutes finding all different trigger points, working on there, and then we send them off. Now, if they go back to this, trigger points are awful things, because once you've activated them, you can get rid of them very easily, especially with this, without any pain or anything like that. But if you go back into this bad posture and everything's having to hold that head like that, the trigger points are going to return and they are going to haunt you. And so it's actually just being on top of these things and making sure it doesn't happen. How do you do that? You actually get rid of the underlying problem. The underlying problem with a lot of these people is posture. And they've been to see people for years and years. And it keeps on coming. Well, you know, nobody can actually sort out, nobody's diagnosing it. Well, I'll tell you what's wrong with you, love. Your posture is just so crap. It's unbelievable. And that's what it is. You're holding that weight out in front of you, 4 kilograms, 4.5 kilograms, and these muscles have said, I'm sorry, I can't do it. And that's what's happening.
I believe you do say that to your patients as well.
I do. You've got to tell the truth.
I've got a couple of questions coming in. Thank you, Gail. I'm going to read this one as it is. Some big words in there for me. So, have you had success using laser with the radiculopathies, either cervical or lumbar, as a result of disc prolapse or nerve root entrapment, secondary to osteophytosis or spondylitic? How did I do that?
What?
Did I do okay there, Gail?
Spondylosis, yeah, I think you're talking about. Yes, yeah, very, very big changes. Again,
have you had success, I suppose?
All sorts of inflammatory reactions going on. We can use this on an anti-inflammatory basis as well. It comes back to my little thing of the machine isn't going to sort out the nerve root entrapment totally on its own. It will actually reduce the thickness of the nerve coming out there by reducing the inflammation. But you see, look, your intervertebral foramen, let's say it's there, and we've got our inflamed, this is the normal size of the nerve going through there. What's happening is we've got some problems here. It's shut down here and it nicks on here. That causes some real problems going all the way down the leg. That becomes thickened because it becomes inflamed. It's like this. So now we've got a real problem. And this is just permanently sticking it on there. What we can do is we can actually now use the laser and actually bring that down to a thinner thing. So we're getting a bit of movement there, but it's still getting caught a little bit. What do we do? We actually open up this. How do we open this up? Your very basic stuff, your Mackenzie extensions, your very first stuff. It depends what it is. If it's just a basic radiculopathy, and these are generally caused by core not being effective, so not offloading from the spine. So the spine's all crushed down, which makes the intervertebral foramen smaller. But then what's happening is you'll find the posture, probably lumbar lordosis right around like that. It just shuts down that intervertebral foramen, makes the whole area smaller. So we just want to open this up, okay? Mackenzie extension, you might think that'll make it less, but it takes the weight off the front of the disc, which allows the pressure to come off here. And then you can do reverse crunches as well, going to take the pressure off the whole disc, open up the whole intervertebral foramen. These are things which you need to do. What is the usual problem we have? That is your terrible pain. You've got the person and they say, I cannot move, okay? I mean, I was stuck in, I was in such pain, I had to call the ambulance. The ambulance comes to give them some bloody diazepam, which are like a muscle relaxant, but it's an opioid and it's not good stuff to have. What they should have done is somehow get on the floor straight away and start doing Mackenzie extensions, okay? And do them correctly, because it's all got to come from the arms. If it's coming from the lower muscles in the back, it'll be compressing a bit. So it's all coming from there. We're taking the pressure off there. And then for 48 hours, as often as they can, get doing 10 or 20 of these Mackenzie extensions, and then a few knee rolls, and just get some movement in that spine. As I said, pain puts people into avoidance, so they will not do anything. What do they need to do? They have to move, because what's happening is this bad problem is that getting worse now because it's even crushed down. We have to move. If we don't move, we've got a problem. What's going to happen here? We can actually use this to decrease the inflammation, reduce the pain, and then we can give them, wave the big stick at them, get moving. That's what we need to do. Obviously not moving anyway. You've got to teach them the right moves to do, and your Mackenzie's extensions are probably the most important thing to do straight away.
Brilliant, thank you. I'll just check with Gail that that's okay on that one.
Yes, thank you. I was kind of assuming that I'm really talking about people who you've tried all those things with, and they're now at a point where either it's steroid injections or surgery. So they've done all their Mackenzie extensions, you've done all the postural correction, you've done all the core exercises, and that's just not working. It's not enough.
And have you used the laser with them as well?
No, I don't have a laser.
Oh, right.
So that's really why I'm asking. I want to know whether I want to get one, and I, there are people I get to a point where I can't help anymore, and will it give me that extra?
No, Gail, see, that's the whole thing. People will not move. They cannot move. And you said that in the Mackenzie's, but everything's in spasm. So they're probably not doing it as well as they should do, because every time they move, their back is just going to a spasm, because messages of pain are going to the central nervous system. The fellows in the central nervous system having the coffee, throw it down and quickly get on the computer and send inhibitory messages back to down here to all your global mobilizers. They go into a spasm, shuts that area down, so we've got a big problem, okay? So they think if I move, I'll try and move, but it's causing me too much pain, and they can't do it. What we want to do is try and reduce the inflammation. We want to try and reduce the pain. Now, with this system, we can, and as Scott Sigmund and his this research on COVID-19, it just shows that it has just such a monstrous effect on inflammation. But at the same time, with the 905 nanometers working, shutting down pain pathways, we've got a double whammy. We've got inflammation, which causes pain. We've got reducing the pain pathways, which reduces pain. And so we've got a double whammy going on. And this is where this comes back to what I've said all along. We, as physiotherapists, we need to get the mobility, and you'll agree with me, yeah? Okay. What we can't do is have people just being in agony and thinking, I can't do anything, and give up. And that's where the beauty of this comes in, because we can use this, we can calm down the whole system. We can use it on muscle contractions, round in the quadratus lumborum, which might be just completely rock solid. We can use it on there. We can actually get on the trigger points. And then we can actually start, even while doing this, see if we can actually start, while we've got this on the back, start trying to get them to do some Mackenzie work on the plinth. You can actually get in there, feel the paravertebrals, and you feel those coming in. So just tell them, say, switch these off, put some pressure on there, facilitate it, switch it off, just let's get all from the arms, and then have the laser going, and we can have some very good effects like that.
Okay, thank you.
All right, great, thank you. Actually, Paul, on the mobilisation bit you just touched on there, I get that asked quite a bit, and in the recent weeks, months that we've been doing these webinars, often, if not every week, we talk about whatever we're treating, whatever each topic was each week, we talk about mobilisation. And I was talking to a couple of practitioners recently, 2 different conversations, but it came up within a week or so. And they were kind of asking, I suppose they were concerned that they would never know all of the kind of mobilisation exercises you might do, but there's no trade secret specific to the laser on those, is there? It's whatever mobilisation you would typically do in practice.
Yeah, well, again, we
do those. So it's not a case of learning a whole load of new kind of mobilisation techniques. It's whatever you did before, but now add the laser. But you're trying to open up the.
Well, as a sort of like just a general rule, we want to get the tissues moving. If they're collagenous, muscular, ligamentous, something like that, when we're treating it, we just get the general movement. What we're actually really looking for on a joint thing, or even on the spine, is we're actually really looking for the optical window. Now, that is a very general rule. So if we're going to the knee or anything, going to the front of the knee, we're going to go into big time flexion, or as much flexion as we can do, because we want to open up the joint and get it in that joint. What the laser cannot do is go through the bone. So we open up the joint and we get it in there, the optical window. And when we're doing the back of the knee, we'll be extending it and getting in the back there. With the spine, when I'm saying do Mackenzie extensions, we're actually, you might argue, I'm even shutting down from where I'm going in, we're shutting down the joint. But if from a complete prone position to coming right up, we're actually getting the gliding, we're getting the movement, and we're getting the laser at the same time. So that will have a good effect. We're getting, again, we're getting the muscle relaxation, we're getting increased vasodilation, we're getting ATP into all the tissues, stop the repair process. We're getting the 905 nanometers inhibiting the pain pathways, and people will start moving better. And that's what we want to do. More generally, if I'm doing a big joint, if I want to get in the back of the shoulder, I'll have this arm right across and I'll be the back of that thing. When I get in the front, I'll be opening it right up here. Why? Because it doesn't go through the bone. But when we're doing something like the spine, we just get this spine moving and reduce the pain at the same time. So in fact, we're probably not going in purely concentrating on that joint, the intervertebral joint. We're actually concentrating on the whole thing, the whole spine, and trying to get some movement in there. Movement is everything. Exercise is everything. Without this, we've got problems.
All right, thank you. Great. Another specific question come in. Thank you, Peter. Asked a little while ago, so thanks for your patience, Peter. What settings would be recommended for plantar plate injury second MAP joint?
For what, sorry?
The plantar plate injury second MAP joint?
Oh, I don't know. That's a real podiatrist thing, I suppose.
It's a capsulitis.
Right.
Second MTP joint.
Yeah. Then what I'd be looking at is just any
Oh, MTP. Sorry, I've read MAP. Sorry.
Anti-inflammatory settings. Again, I would start off lower power, but try and get some, even if it's passive movement in that joint while you're doing it, as we're moving it. Open it up as much as you can when you can, but just if the patient is really unable to actively move it themselves, what would I use? I'd probably start off on my general pain setting, which my base one 700 hertz. So you're in the middle of the hertz thing. You've got some mechanical effect. You're not seeking massive mechanical effect too. Depends on the chronicity, everything like that. But we'd be looking at 50%. Again, smallest joint, 5 minutes. And then I would see how it goes. If I don't get any results with that, it's not because the machine doesn't work. We probably need to get some more in there.